Hello, I'm LaTanya Turner. As you've just seen, Nashville faces some serious issues regarding infant mortality and premature birth. This second episode in the NPT Reports Children's Health Crisis series is part of a 3-year effort by Nashville Public Television to raise awareness and start a community-wide conversation on the health of Tennessee's children. And to help us continue this conversation, we've invited 4 health professionals into the studio. They are Dr. Melanie Ludenbacher, Associate Professor of Nursing at Vanderbilt University Medical Center; Tamara Curran, Associate Director of Program Services with the March of Dimes Tennessee Chapter; Dr. Kimberly Weish Etheridge, Director of the Bureau of Family, Youth, and Infant Health at the Metropolitan Public Health Department of Nashville and Davidson County; and Dr. Michael D. Warren, Medical Director for the Governor's Office of Children's Care Coordination. Thank you all for being with us today.
Thank you.
Well, we've just seen a pretty dismal picture for Tennessee when it comes to infant mortality. So the first question I have is, why is Tennessee so much worse when it comes to infant deaths than other states? Dr. Warren, why don't we start with you?
Absolutely. I think our infant mortality problem is reflective of our larger health condition. And certainly when we look at other health conditions like heart disease, diabetes, high blood pressure, Tennesseans are generally less healthy in regards to those conditions than are citizens of other states. And so we have a population that then is set up to have worse birth outcomes, whether that's a premature birth or whether that's to have a baby who subsequently dies.
Okay. We talked about premature births quite a bit in the report that we just watched. What is the significance, or where does that rank in terms of contributing to this problem of infant mortality in Tennessee?
I think that, first of all, if we know that we're having too many babies born, too small, too early, too fragile to survive, then we're behind the 8 ball from the beginning. These babies also grow up to have additional health disparities, which puts us back into that same cycle. So as a result of the prematurity alone, we know that our statistics are going to be worse.
Okay. And that seems to not be the case in other states that we learned in doing our research for the documentary. In other states, it seems that there are other factors that lead the way when it contributes to infant mortality, like birth defects. We're all familiar with SIDS. So where do those fall in Tennessee?
Just to add to that, I think that one of the important things, just like Dr. Warren said, we have a population that's not healthy. We have a community that's not healthy also, and place really does matter. And Tennessee, in a lot of ways, is the perfect storm of the poor health of the people, the poor environment, the poor way that a lot of our communities are set up as far as resources. And when all of those things converge together, it turns out to be a perfect storm.
Okay. And Tamara, we all are familiar with the March of Dimes and the work it has done, and a lot of people may associate that organization with birth defects, yes. But you now are taking on some of the challenges of dealing with prematurity. Maybe you could talk a little bit about the role of prematurity and infant mortality and birth defects and how they relate.
Absolutely. The March of Dimes mission definitely encompasses premature birth, infant mortality, and birth defects. And we are more known, I think, historically for our work around polio, as well as our work with birth defects prevention. But as we continue to work through, helping mothers and babies become healthier, we started to see that, premature birth was a huge issue. And then looking at the incidence of premature birth, it still encompasses, babies born early, likely to have some birth defects when born, at increased risk for infant mortality. So we launched our prematurity campaign in 2003. And the basic premise behind that campaign was to raise public awareness of the problem of prematurity, because first, if you don't recognize that it's an issue, then there's nothing that can be done to address it. And then also to lower the incidence of premature birth to align with the Healthy People 2010 goal. Here in Tennessee, we have approximately 15% of our babies born prematurely, and our Healthy People 2010 goal is 7.6%. So we're almost double what that goal is. So there's definitely lots of work to do. Okay. But looking at that premature birth is our overarching problem, and then infant mortality and birth defects definitely being some consequence of that condition.
Okay. Dr. Ludenbacher, what is the long-term effect of what we just heard from Tamara of premature births?
There's lots of long-term consequences for babies that are born early. They can have lots of chronic conditions, they can have learning disabilities, lots of handicaps, and it really causes a great stress on themselves and as well as their family and on society.
Let's talk a little bit more about that. What does it mean for the broader community or even the state when these children are born premature and survive and have these challenges?
Well, when they have these challenges, then we have a lot more special needs children in our state, which we do have a high rate of special needs kids, and that puts an additional burden, if you will, on us and on our educational system. And so we have to have a lot of specialized programs to deal with those issues and settings, and
that costs.
It costs lots of money.
It takes resources.
Lots of money and resources.
Okay.
Absolutely, and I think Dr. Lutenbacher is spot on. If you have a baby who's born at term and goes to what we call the normal newborn nursery, where everybody looks in the window and sees the baby in there, that birth visit might cost a couple of $1,000s. Whereas a baby who's born prematurely, that cost quickly gets into the tens of thousands of dollars. And for every week that that baby is born earlier, the cost goes up. But I think we focus on that a lot, but what we can't lose sight of is that the long-term cost. And so Dr. Lutenbacher talked about the cost on the educational system, other support services, but also the cost on the family. So many of these babies go home with specialized equipment, feeding tubes, breathing apparatus that require a lot of extra time and effort on the part of the family. And so those kind of resources are also strained for these premature children.
Well, which then impacts the families as well for being able to work. A lot of families, a lot of parents have to give up their jobs, and so that also causes more stress on the families. So
and that's an impact on the businesses as well.
Exactly.
What about prenatal care and where that fits into all of this? A lot of people think of prenatal care. A lot of us think of, you know, the early months of pregnancy, but I know that many of you feel that begins before conception. So let's talk a little bit about that and how the health of the mother prior to conception impacts this.
Where do you want to start? I think that, that's just the issue of preconception health, or health prior to, as you said, a family even considering having a child, is so key, because as we've all heard and Dr. Warren mentioned, I believe in the video, you can't undo 30 years of health insults in 9 or 8 months of prenatal care. It's just not possible. So until we start really focusing on how are we taking care of our women prior to pregnancy, even when they're young girls, even when they're in mom's womb, is key to their health outcomes later on in life. We know that babies who are born to moms who are stressed have a better chance of being obese. Okay. And if that woman then is obese and ends up getting pregnant, then we know that we have issues around what kind of birth outcomes she might have.
Let's talk about health disparities, which came up a little bit in the report. And what exactly does that mean, and how does it relate to infant mortality?
A disparity is where you see different health outcomes in one population versus another population. And in Tennessee, we experience disparities in almost every category, from our infant mortality, where an African-American baby is 2 to 3 times more likely to die before its first birthday, to the difference is in obesity, heart disease, diabetes, cancer, even the years of expected life expectancy are different. And when it's different between different populations, which can be based on race, it can be based on ethnicity, it can be based on socioeconomic factors, and where you live. All of these things can fold into what your health outcomes can be expected to be. And that's something that needs to be addressed really at the community level.
Well, and how can it be addressed? What can be done? Tamara, you want to take that?
I think with all the factors that Dr. Kim mentioned, that it definitely takes a multi-systemic approach. It can't just be the healthcare industry to address problems like socioeconomic status or poverty, or you know, various issues that relate to race relations in the past. So it takes a various you know, group of individual organizations to really impact the problem. So there are a lot of systems that have to change in order for us to see a real result.
That seems to relate to another term that we heard in the documentary, cultures of health. And I wonder if one of you wants to explain a little bit more about cultures of health, how that relates to health disparities.
I think culture of health really gets at the notion of broadening this concept of health that we have. Right now, I think we view this very narrowly, and we think about health in terms of health care, and a child or a mom or a dad comes in for an office visit or they go to the hospital. But when we think about culture of health, we think about really changing everything that touches our lives on a daily basis. So placement of sidewalks in neighborhoods so that families have places to walk and be physically active in a safe way. Rules that allow for fresh fruits and vegetables to be in close proximity to neighborhoods. So how do we determine that a supermarket or a farmer's market goes in a certain area? How do we engineer the workplace so that we support breastfeeding moms who need to take a 30-minute break to go and pump, or to have a place in public where a mom can breastfeed? It really gets at that broader aspect of health.
I think added to that is also the issue of expectations. A culture of health has a community that expects to be healthy, that you expect to have the opportunity to have a healthy baby, to live a long life without disability. And when you have a community or a society that doesn't expect that, folk are more willing to kind of settle for poor health outcomes. And then it's harder to change that.
And do you really think there's a lower expectation here about that? And how does that compare to other states? Or do other states have a higher expectation of health care?
Some states do, some states don't. And if you look at the states that have similar characteristics that we do as far as health behaviors and population and so forth, they're down at the bottom where we are with infant mortality. And those states that do value health and they do look at community-wide programs and things like sidewalks and groceries and school programs and so forth, they do have better outcomes.
How much of that relates to resources, though? Maybe it's not the expectations. Maybe it's that those states have more resources or know how to use the resources differently. How much of it relates to sort of that component of it, managing your resources and policies?
I think those cycles probably contribute to each other.
Okay.
If you're in an environment where resources have not been allocated in a way so that it makes it easy for you to engage in those behaviors, you may then come to develop that expectation. It's almost like a self-fulfilling prophecy.
A good example is that just looking at education, there's a community that we had the opportunity to visit where in the downtown on all of the light posts, there was a flag that said, "Everybody read." And they were creating a culture of the importance of education. Very low cost, but it was a very subtle expectation. That same community, there were bike racks on all of the public buses, and an expectation that you will walk or you will ride your bike. And so just subtle things like that change the attitudes.
What is being done to improve infant mortality in Tennessee? What are some steps that are being taken?
So there are numerous things going on in Tennessee, and I think we should pause to say that while our infant mortality rates are much higher than we'd like them to be right now, there are great strides being made in Tennessee. And if you look at the infant mortality rate, even over the past couple of years, it's starting to trend down. It's creeping down. It's a small creep, but we're getting there. In terms of what's being done, I can address that certainly from the standpoint of the administration. The Governor's Office of Children's Care Coordination administers the infant mortality and women's health funds across the state. And when that funding was initiated, we looked at where are the problem areas in Tennessee, because you have to be data-driven when you attack problems like this. And we noticed that infant mortality rates and numbers were highest in Shelby County, Davidson County, and Hamilton County. And so we established community groups there called core leadership groups, because we firmly believe that local groups know what the local problems are and how best to solve those local problems. And so out of that have grown things like centering pregnancy, like community voice, Project Impact, where we have youth peer messaging, a number of programs across the state aimed at this.
We saw a little bit about centering pregnancy in the report. Let's talk some more about that. Yes. What is that? It really is about peer networking and collaboration, isn't it?
Absolutely. It's a non-traditional care setting. Whereas, the traditional time in a doctor's office is very brief. You know, we know our doctors don't have a great deal of time to answer a lot of questions, but in the Centering Pregnancy program, it is set up for a group of women, usually 8 to 10 women, which we've seen in the footage already, that really meet together around the same gestational age of pregnancy and not only receive their care in terms of listening to baby's heartbeat, measuring growth, blood pressure, things of that nature, but also a group peer network, developing that support and having more time to get educational messages about breastfeeding and the importance of that, infant massage.
Feeling like you're not in it alone. And
Absolutely.
What kind of results are you seeing from that type of work?
I was just going to add, and they're actively involved in the process as well, even in the clinical parts, as far as measuring and listening to the heart rates and that. So they really are empowered to be start looking at their own body and the body functions and being in control of that. So that, you know, that's very important. Right, exactly.
Rather than passively being
I present
patient.
myself and my body, and it's done. So I think that's an important experience for a lot of women.
And it seems like that's something that could be duplicated, replicated. Without a lot, is it being replicated quite a bit?
Absolutely.
Yes, it is.
There are a number of sites across the state, not only the ones that we fund, there are a number of centering sites. And the nice thing about something like centering is it's sustainable. Prenatal care is a billable service. And so in this way, we've got a program that has already shown promising results in other states, but already in Tennessee we're seeing promising results. But it also can start to pay for itself, which is so important.
Is there any way that you can define what you mean by promising results? Can you talk about that a little bit?
Absolutely. So certainly in Tennessee, all the programs that we fund require an evaluation. Again, we are very focused on data and making sure that we're being as responsible as we can be with state money to make sure we're getting the most results. And what we have seen is that women who are entering our centering pregnancy programs have not only shown increases in knowledge about infant care, knowledge about their own health, but they're also delivering less frequently early. And so they're more likely to carry their baby to term, more likely to have a baby born at a healthy birth weight. And we've seen those results right here in Tennessee.
And they enjoy the prenatal care more. So they're more connected to it. And therefore they follow up with their appointments, look forward to it. And in some of the groups, the fathers are actually invited.
Yes, we saw that in the video. Let's talk about some other programs that are helping with this. Centering pregnancy, what else is being done, Dr. Kim?
Well, locally, there's a lot of programs that involve peer educators. We work with college students and graduate students to actually train them as preconception peer educators and then have them in the community talking to individuals, talking to groups, talking to their classmates. And as a result, we know that education is always better when it's horizontal, from peer to peer, opposed to vertical. And that's one wonderful way and a very, very inexpensive way to get information into the community, because we know that education is key. Knowledge is probably one of the biggest answers to this. If you know what's happening, and if you know what you're missing, then you're more likely to hopefully try to seek it out. Opportunities to match women in the community with a pregnant young woman or a pregnant older woman in the birthing project, a great way, again, low cost, bringing the community into the picture. There's no way the medical community is going to solve this. It's got to be done at the community level, and the community has got to take responsibility for solving some of these problems. So any program that really is on the ground, at the ground level, in the forefront of the battle, is going to be very successful.
That's a very interesting point, and it came up in the report. This is more of I think the comment was, this is more of a social challenge, or as much a social challenge as it is a healthcare challenge. If someone is watching this program at home, what can they do to help with this community-based approach? What can any individual do?
Well, I think one of the things that's really important is that people educate themselves about the issues and understand that there's not just one problem, one cause, one factor, but understand that there's a lot of issues that impact it, and that they can start with simple lifestyle changes themselves, and that will impact the health of their family, the women in their family, their friends, their colleagues, and so forth. So even if we just started with knowledge about smoking and nutrition and obesity and those sorts of things, that would be an incredible improvement. And also when women are pregnant, as soon as people are aware that they're pregnant, to try and get them into services as soon as possible so that they can be matched with the best program, whether it's centering pregnancy or clinic visits or community project, or we're involved, we have a research project going on where we're testing a home intervention, where we're using certified nurse midwives in the prenatal period along with clinical intervention to try and deliver services to very high-risk women, so women who've already had a preterm birth. So trying to find that best match very early on, and so a lot of community members could really help with those kinds of things.
And I guess we all contribute to the culture of health and the expectation impact that you were talking about earlier, correct?
Sorry, go ahead.
Okay, I was just going to say, just looking at the community, just one program in particular, Community Voice, which is active here in our state. Just really looks at educating what we call the lay health educator. So not our traditional, public health department or March of Dimes staff or volunteers, but really looking at members of the community that is experiencing some of those health disparities, and educating, the beautician or the barber in the community, or, the elderly lady at the end of the street who encounters, those who may be at risk for certain health conditions, and can disperse those messages in a more casual and accurate way.
I think that is so important, because that's something that we've really found, and we hear that with the women in our study. What really makes a difference is the relationship that they can have with one person whom they absolutely trust, and that person they perceive that they have the expert knowledge in order to give them the information they need and the education, but in a way that they understand it. And it's in the time that they can use it and really act on it. So I think that's a really critical part.
And it allows for those teachable moments.
Right,
whereas,
exactly.
If you don't happen to be in a classroom setting where you're there to get the education, but you are having your hair styled or having your hair cut, and you come in, you happen to be pregnant, and there are messages
or like
that
the young
can be
woman said in the report on the bus, educating people.
And that was great.
And another person interviewed in the documentary talked about changing attitudes about breastfeeding. Something as simple as that, it seems, goes a long way, because it kind of changes the attitudes and expectations, correct?
It does, and I think it underscores the need that we've got to think outside of traditional healthcare. So it used to drive me crazy when I was an intern to talk to a mom about why breastfeeding is so important, or why you shouldn't have your child drink so much juice. And what I quickly realized was that if I didn't get grandma on board, then everything that Dr. Warren said didn't matter at all. And so you've got to get to those other people. Grandma is a trusted source in the South for health information, or your pastor, or your beautician. How do we get that information from somebody that we know to be reliable?
And just to add to that, I think that we've shifted the community to turn away. And I think that getting the community to care and to take ownership in our babies is probably the foremost thing that would make a difference.
What do you mean, Dr. Weishathridge, about shifting the community to turn away?
How comfortable would you be if you're walking down the street and see a pregnant woman smoking a cigarette, to go up to her and say, your baby's smoking also? Would you consider putting that cigarette out until your baby's born? We'd rather turn away and say, I can't believe she's smoking. How comfortable would you be if you're on a bus and there are no seats and a pregnant woman is standing there, to ask somebody, could you please get up and let this woman sit down? Things like that, where we actually wrap around our pregnant women as a joy and as a treasure, opposed to as a bother.
That's a tough thing for a lot of people to do.
But
So
I think that's what would make the
you would have to get
difference.
out of your comfort zone.
Most definitely.
Is that what you're wanting people to do?
Yes, and get back to the issue of it takes a village to raise a child. It takes a village to comfort a pregnant woman. It's not just that woman's responsibility, and it's not just that physician's responsibility. It really is the community. That baby is born into a community. It's our future. It's not just that woman's, and we have to start treating it that way, so that we all can, enjoy a healthy baby, but mourn over the losses of one that doesn't make it.
What would you like to see happen? We have just a few minutes left. Let's start with you, Dr. Lutenbacher. What would you like to see happen with this challenge of infant mortality?
I think I would like to see the continuation of some of the efforts that have started, and the coordination. I feel a lot of synergy that's occurring in the state right now, and I would really like to capitalize on that, and so that we can pull together these programs, the non-traditional programs as well as the traditional, together, and really make a comprehensive system of care, if you will, but care not in a traditional sense, and so that we really do change that culture.
What about you, Tamara?
I would like to see a more coordinated effort, just partners not working so much in their bubble and addressing, their particular issue. But when we look at, our culture of health as a whole to address any health concern, prematurity, infant mortality, but really pulling in the right partners to address those issues from various angles.
Dr. Warren?
I'd also add from the state government level, continued emphasis on how we can make good health policy that improves the baseline health of all Tennesseans. So the Non-Smoker Protection Act, programs like the Tobacco Quit Line, programs like Project Diabetes and Get Fit, go a long way in raising the baseline health. And when all of us are healthier, babies in Tennessee are going to be healthier.
Okay. And Dr. Weiss Etheridge, what about you?
I think building on what everyone else said about the importance of what we call our non-traditional partners, there's a great saying that said if you keep doing the same thing and expect different results, that's insanity. So we keep talking to the same people and partnering with the same people and we're getting the same results. Getting to the idea that place really does matter. If we have the housing people at the table and realize that where a pregnant woman lives has a good impact on her outcomes. The transportation people, if you have to take 5 buses to get your prenatal care appointment, that's going to affect birth outcomes. The Chamber of Commerce is talking about where, as I think Dr. Warren said, where your grocery stores are situated, where your fast food stores, or where your liquor stores, all of these things together.
Well, thank you all very much. You've given us some very important information to think about, and I want to thank all of you for joining our conversation tonight. You can learn more about the children's health crisis in Nashville by going to wnpt.net/children's health. Stay tuned to NPT for continued coverage of this issue, and we want to hear what you think. Write to us at tv8@wnpt.net or call our viewer comment line 615-259-9326. Thank you for watching.
Major funding for NPT Reports, Children's Health Crisis, has been provided by the Healthways Foundation, addressing the critical issues of children's health and public education, the Nashville Healthcare Council, the Monroe Carroll Jr. Children's Hospital at Vanderbilt, getting children well on their way, Vanderbilt University's School of Medicine, Department of Pediatrics. Additional support provided by the Orrin H. Ingram Fund and by members of NPT. Thank you.